UFT, and she's in fact a super specialist in this area of diabetes within endocrinology, and she's the director of diabetes complication clinical research laboratory at Sunnybrook, and has an impressive body of work in this area, and I welcome you to speak about emerging trends. Thank you.
Well, thanks very much for the kind introduction. Good morning, everyone. So nice to be here at this event with an audience that's so engaged in type 2 diabetes and vascular complications. Once again, I'm an endocrinologist as well as a clinician scientist, and my area of research is in diabetes complications with a specific interest in heart and kidney disease. Before I begin, here are my disclosures. I do a lot of research and work in an area that is of interest and relevance to the pharmaceutical industry. Here is my commercial support. There was no commercial support for this presentation. And here's how we've mitigated against bias and just educating you in terms of my potential relationships. My goal is to talk about emerging trends in diabetes research, and at the same time, I think it's relevant to talk about new changes in type 2 diabetes management, conversations that have already begun with wonderful presentations by Robin and Zania as well. So as we've all heard and are all interested in type 2 diabetes, it is a massive burden, no question. One of the good news stories is that we are attenuating the burden of complications. How? Through more awareness, through new drugs, and more attention, I think, and focus in the diabetes space. In terms of complication, no surprise to this crowd that microvascular complications are a major source of morbidity. 1/3 of patients developing end-stage renal disease secondary to diabetes. Retinopathy, I'm not sure if you're aware, remains the leading cause of blindness globally in the working age population, very important complication. And of course, no surprise to this crowd, that neuropathy, of course, is an important complication as well, increasing the risk for lower limb amputation. Having said that, though, there's a lot of attention and focus in type 2 diabetes, particularly in the last few years in cardiovascular disease. We know that type 2 diabetes and type 1 diabetes, the leading cause of mortality, is cardiovascular disease. And that, in fact, if you look at estimates of life expectancy, the presence of type 2 diabetes and cardiovascular disease reduces life expectancy and causes premature mortality by 12 years. So I was asked to speak about emerging research trends. And this is a massive topic, of course, because there's a lot of interest in pharmacology, in technologies, and many areas of diabetes. And I'll just point out that some of these areas presently are mostly technology driven. Basically, on your right hand, one of the areas of interest, particularly in type 1 diabetes, is this idea of having an artificial pancreas, very close to having this actualized. So actually having an insulin pump, working together with continuous glucose monitoring, and having closed loop systems so that all of the operation is done through technology. The other promise, particularly in type 1 diabetes, we have islet cell transplants, the Edmonton protocol being an important aspect of this, but there are challenges to using pre-existing beta cells. So of course, a massive area of research and development is using stem cells, using progenitor cells, and asking the question if we can grow new beta cells. Of course, apart from all of the pump work, there is a lot of interest in developing diabetes technologies. Everything from contact lenses that sense glucose to a number of apps, whether it is ECG monitoring by smartphones or heart rate monitoring and having that information to your endocrinologist, or even retinopathy telemedicine, which is already happening. So we have further outreach to communities that don't have access to tertiary care like we have in Toronto. So lots of research. What I'm going to focus on, though, is the area of new drug development and focusing in on what we know about existing drugs. Massive amount of research, particularly in the type 2 diabetes space. You've already been introduced to this concept earlier. that fortunately now in the area of type 2 diabetes, we have two newer drug classes, sodium glucose cotransporter 2 inhibitors. From here on in, we'll call them SGLT2 inhibitors, and GLP-1 receptor agonists, which have many effects beyond blood sugar lowering. So while the previous sort of 20, 30 years have been exclusively focused on glucose lowering, where we're going to now, it's already happening, and moving forward, is going beyond glucose, looking at those effects beyond blood sugar lowering. So these particular drug classes have effects in the kidney, in the heart, on weight loss, and in the GI tract, as an example. And so I'll just quickly remind you, how do these drugs lower blood sugar? Well, with SGLT2 inhibitors, they are a tablet. For instance, empagliflozin, also known as Jardiance, or Invokana, known as, or canagliflozin, known as Invokana. As you can see here, they act at the level of the kidney. They cause you to pass more sugar in your urine, as well as salt, which we'll come back to in a moment, and that's the sugar-lowering effects. Whereas GLP-1 receptor agonists, they are an injectable. Now we have once-a-week injectable therapies, which allow many patients to treat their diabetes with once-weekly injection. And those drug classes include liraglutide, so Victoza, the once daily, and now newer dulaglutide, which is once weekly, as well as semaglutide or Ozempic once weekly. The way these drugs work is to actually go to pancreatic beta cells and cause insulin release and decrease glucagon in order to improve blood sugar. But actually, that's not what we're going to be talking about today. What we're interested in, I thought would be interesting discussion with this crowd, is to talk about the cardioprotective effects observed with these drugs. So all of this came actually from the FDA requirement in 2008, which made it a requirement for any new drug to have a cardiovascular safety trial done. The reason being is previous drugs have been associated with increasing cardiovascular risk. So very rightly so, the United States as well as Europe made this requirement for all new drug regulatory approval to have cardiovascular safety drugs. As you can see in purple, the first drug class that this was exposed to were the DPP-4 inhibitors. And the first results came out as neutral. In other words, DPP-4 inhibitors, drugs that lower blood sugar, showed cardiovascular safety in patients with type 2 diabetes at high cardiovascular risk. This was reassuring that we had drugs that were safe, but where the energy has now been refocused has been in the SGLT2 inhibitor space, where we have two trials showing a positivity for reducing MACE, so major adverse cardiovascular outcomes. And that space has been driven mostly by a reduction in heart failure, as well as in diabetic kidney disease protection. And I think what's relevant to this class is that these trials were done in patients with type 2 diabetes at high cardiovascular risk. One of those risks which allowed you to be in these studies was to have peripheral arterial disease. Okay, so this is relevant to your patient population. The other class being the GLP-1 receptor agonists. We now have several trials in patients with type 2 diabetes at high cardiovascular risk, showing a reduction in cardiovascular events. This is in addition to ACE inhibitors, to statin, and the idea was to keep the blood sugar equal, in other words, to have glycemic equipoise. So we really have found out a lot of information from these studies that there's cardiovascular protection with these drugs, and it's relevant to this patient population. The results have been so impressive. As already mentioned, they've changed guidelines for the way we manage patients with type 2 diabetes and cardiovascular disease. In fact, Diabetes Canada was one of the first in the world to recognize this. If you just see there in the middle, does this patient have type 2 diabetes with cardiovascular disease? If yes, then after metformin, the second drug that should be considered in your patients with type 2 diabetes is either an SGLT2 inhibitor or a GLP-1 receptor agonist. That was in 2016. This past fall, the Europeans and Americans caught up and they said, we agree with you. They took it one step further and they said, your patients with type 2 diabetes who have cardiovascular disease, atherosclerotic cardiovascular disease, prioritize GLP-1 receptors. Why? Because they are anti-atherosclerotic. If the predominant issue is heart failure or diabetic kidney disease, first consider an SGLT2 inhibitor and then consider a GLP-1 receptor agonist. So what do you expect when you have a SGLT2 inhibitor? Some modest A1C lowering, and that's through that glycosuria effect. But you can expect other things as well. There's a reduction in body weight, a reduction in systolic blood pressure, and that's related to those natriuretic effects. So again, this drug causes a release of glucose, but also reduction in salt. And that's what reduces plasma volume by getting rid of salt, and it also protects the kidney, and we think that's where the effect on heart failure comes in. So lots and lots of research is being done on this area to better understand these effects. I guess as an endocrinologist, I do want to point out that the A1C lowering effects of these drugs is dependent on GFR. So many of my patients with type 2 diabetes have some form of renal dysfunction. So the less renal function you have, the less blood sugar lowering you're going to get from this medication. So I always have to think about that as an endocrinologist. So just to point that out. How do they lose body weight? Patients lose body weight on SGLT2 inhibitors for different reasons. One is losing volume, so passing out more, the diuresis, losing more plasma volume. And two is by reducing calories. As you excrete glucose in the urine, you're reducing your calorie load. And you also get a drop in systolic blood pressure. Be mindful that there may be a small dip in eGFR when you start these drugs. That's actually thought to be a protective effect in the kidney. It's reducing hyperfiltration in those hyperfiltering kidneys. The GFR should come back up to baseline. One thing to know about 10% of patients get mycotic genital tract infections and urinary tract infections. So be mindful of this. Relevant to this crowd, there is a risk for amputation for canagliflozin. That was observed in the CANVAS trial. So there is an FDA warning. The absolute risk is very, very small. Who does this happen in? Patients who've already got pre-existing peripheral vascular disease. And what has been very reassuring to the diabetes community is roughly about 3 weeks ago, the CREDENCE trial, which was the first dedicated kidney study with an SGLT2 inhibitor, had no increased risk for amputations. I think this had to do with a lot of the fact that mid-trial, they changed the protocol and they said, let's do monthly foot checks. And by the end of the trial, no increased risk of amputation. So I don't think there's actually a mechanism there supporting it. And I think that we might see in the future this FDA warning removed. Just in terms of practical questions, perhaps we'll go back to this in the question period, because I do want to spend a moment speaking about GLP-1 receptor agonists. They are an injectable once-weekly therapy. They are daily available, but most of my patients prefer once-weekly. Very potent on reducing A1C. The majority is at least 1.5 to probably 2%, depending on the patient, of course. Body weight loss is through direct effects in the brain to say, stop eating. There's a satiety signal. And there's also blood pressure effects, a mild effect on natriuresis. And again, expect cardiovascular protection in your patients with diabetes, different than the SGLT2 inhibitor space. These drugs are thought to be much more anti-atherosclerotic. The cardiovascular protection with these drugs are not seen until at least 18 to 24 months. So we know that it's working on pathways that takes time to modify. Most of the preclinical studies, clinical mechanistic studies have some strong support for anti-atherosclerosis. We don't have all the answers. There may be many mechanisms, but it does definitely look like an anti-atherosclerotic effect. What to remember? Well, their A1C lowering has nothing to do with kidney function. So in patients that have very reduced kidney function, you can still expect robust A1C lowering. Very important to me as an endocrinologist. Most common side effect for sure, 10 to 20% of patients have nausea and vomiting. There are GLP-1 receptors expressed in the GI tract. Roughly after a month, maybe as long as 2 months, there is this nausea and vomiting in a lot of patients. It's a relevant. I tell patients about it. What we do to mitigate this is to start at lower doses. The doses need to be titrated over time. I think you are going to see a lot of use of these medications in your patient population, and that's why I want to spend some time reviewing them. Again, also through a cardiovascular crowd, there is an increase in heart rate with these drugs. So again, for folks that have got tachycardia over 100, not recommended. Not a lot of studies, I'd say, in patients with known arrhythmias. So again, in terms of mechanisms, a lot of research in this area. The leading mechanisms for SGLT2 at this point in time in terms of their cardiovascular protection is natriuresis. That helps locally in the kidney. It also reduces plasma volume. That's why we see a reduction in heart failure, as well as protection in the kidney. And there are ongoing trials right now in patients without diabetes. So again, nothing to do with sugar lowering, but to do with sodium lowering, and we'll see the outcomes of these studies. Presently only approved for type 2 diabetes, and with the GLP-1 receptor agonist, we have an anti-atherosclerotic effect. So in terms of management, the landscape for type 2 diabetes and cardiovascular disease dramatically changed in the last few years. I think we'll see a lot of new developments moving forward. SGLT2 inhibitors, heart and kidney protective. Okay, it's hemodynamic or natriuretic. GLP-1 receptor agonist, cardiovascular protective, likely also good in the kidney, and anti-atherosclerotic. What clinical research questions will there be moving forward? A lot of these studies have been done in patients with type 2 diabetes with pre-existing cardiovascular disease. Next week at the ADA, American Diabetes Association meeting, we'll hear for the first time the trial results of a study where the majority of the population with a GLP-1 receptor agonist was a primary prevention population. So that's the questions, those are the next steps we need to learn. We're also going to be maybe using these drugs in patients who don't have diabetes. I think there needs to be a lot more work done in the area of peripheral vascular disease and these drugs, and understanding if there's potential benefits in this area as well as root healing. So to keep this session interactive, I know we had a very short time together. Let's see what we learned about GLP-1 receptor agonists. Which of the following statements is incorrect? Too many is there about GLP-1 receptor agonists. 1, it decreases A1C 1 to 2% as on average. They lower body weight for number 2. 3, they're protective for the heart and cardiovascular system. 4, they shouldn't be used with a DPP-4 inhibitor. Or 5, nausea is the most common side effect. Very smart crowd. So 70% said 4, it shouldn't be used with a DPP-4 inhibitor. Why is that? That works on endogenous incretin pathways, endogenous GLP-1 pathways. With a GLP-1 receptor agonist, we are at pharmacological or super pharmacological levels and directly impacting GLP-1 receptors. So we don't need that DPP-4 inhibitor. That's polypharmacy and lots of extra money spent. I think that's all the time I have. Thanks so much for inviting me and for your attention.